Good afternoon, everyone. My name is Jessica Turton. I am a dietitian and nutritionist with a PhD awarded by the Faculty of Medicine and Health at the University of Sydney. So, thank you, Liz. In this presentation, I am going to talk about the role and efficacy of low-carbohydrate diets in diabetes management, with a specific focus on type 1 diabetes. I will be presenting the results from our clinical trial that we completed last year, and this was part of my PhD thesis. So I think it's always important to talk about the different types of diabetes, the similarities, the differences. Now, with type 2 diabetes, we know that the characteristics include high blood sugar levels, insulin resistance, and high insulin levels. People with type 2 diabetes may be at risk of hypoglycemia, so low blood sugars, if they are taking certain glucose-lowering medications. Insulin production is usually very high in type 2 diabetes, but individuals experience a relative insulin deficiency because their pancreas cannot keep up with the high glucose demand. Absolute insulin deficiency may develop in advanced stages of type 2 diabetes, and insulin injections may be required. Type 1 diabetes is an autoimmune disease where the beta cells of the pancreas have been destroyed and can no longer produce sufficient insulin. So affected individuals have to administer calculated doses of insulin multiple times a day for the rest of their lives. The onset of type 1 diabetes is far more rapid than that of type 2, and individuals can become very unwell leading up to their diagnosis. People with type 1 are at risk of high and low blood sugar levels due to the inherent difficulties in predicting exogenous insulin requirements. Due to the increasing prevalence of insulin resistance in people with type 1 diabetes, experts are describing an epidemic of double diabetes, where the characteristics of type 2 diabetes are being displayed in people with type 1. A recent systematic review examining the global prevalence of metabolic syndrome in individuals with type 1 diabetes showed that almost 25% of people with type 1 had the metabolic syndrome, and Australia has the highest rates worldwide. So with all of that considered, the main target in diabetes management for all types of diabetes is to control blood sugar levels within a safe, healthy range. These are the blood glucose levels of someone who does not have diabetes eating a pretty standard diet. Across the 24-hour period, you can see this person's blood sugar levels fluctuate slightly depending on what they eat, what activity they do, what stresses they experience, but the levels predominantly stay around 5 millimoles per litre. And this is the equivalent to about 1 teaspoon of sugar in the entire bloodstream. These are the blood sugar levels of someone with type 2 diabetes. Firstly, you can see this person's baseline blood sugar levels are no longer sitting at 5, they're sitting around 10, double what they should be. And when this person has something to eat around dinner time at 6 p.m, you can see their blood sugar levels rise even higher into the teens, and it takes quite a while for their blood sugar levels to come back to baseline, and that's due to the severe insulin resistance. When blood sugar levels are too high like this for too long, glucose starts sticking to the proteins in the body and causes damage, and this is a process called glycation. This is what increases the risk of diseases like heart disease, blindness, kidney disease, and limb amputations in people with diabetes. These are the blood glucose levels of someone who has type 1 diabetes. You can see this person experiences quite drastic high and low blood sugar levels in a short period of time. And that's because it's extremely difficult to predict what your blood sugar levels are going to do and then accurately calculate the right dose of insulin to maintain your blood sugars within a safe and healthy range. So let's look at the role of diet. This simplified graph shows how the 3 main macronutrients in food affect blood sugar levels. As you can see, carbohydrates have the greatest impact on blood sugar levels relative to proteins and fats. And that's because all carbohydrates, so all starches and all sugars, break down to glucose in the blood. So with consideration that the primary management target in all types of diabetes is to control blood sugars within a safe and healthy range, a diet that is low in carbohydrates makes sense. So what we see in most successful low-carb diet studies is that a specific target for carbohydrate prescription is provided. Carbohydrate restriction, is provided, and this is somewhere in the range of 0 to 130 grams of carbs a day. On the other hand, the prescription for fats and proteins is generally set as high or ad libitum. And this means that the recommended sources of fats and proteins are increased to a defined target or consumed to satiety. Healthy fats from minimally processed foods are an important source of energy, and they provide fat-soluble vitamins like vitamins A, D, E, and K. And as you just saw, they have a minimal impact or a stabilizing impact even on blood sugar levels. Proteins are not a source of energy, but they are the building blocks of our bodies. They form our muscles, our skin, our connective tissue, hormones, enzymes, bone, and more. Animal-based protein foods like meat, fish, eggs, and dairy are also some of the most nutrient-dense foods, providing key micronutrients like iron, zinc, B12, and calcium. Although we know a lot more about low-carbohydrate diets now, they aren't anything new. Strict low-carbohydrate diets were the original treatment method for diabetes prior to the discovery of glucose-lowering medications and insulin. This screenshot is from a medical textbook published in 1921, which describes the dietary requirements for a person with diabetes. As you can see, the diet prescribed included foods without sugar, such as meats, poultry, game, fish, clear soups, gelatin, eggs, butter, olive oil, coffee, tea, and cocoa. Low-carbohydrate diets are one of the most well-studied dietary approaches for type 2 diabetes management. There are now multiple high-quality systematic reviews from research teams across the globe that show, compared to standard low-fat, high-carbohydrate diets, low-carbohydrate diets are the most effective for reducing HbA1c, reducing reliance on blood glucose-lowering medications, improving weight, and improving heart disease risk factors, and that's in people with type 2 diabetes. So it's no secret that low-carbohydrate diets are the most effective dietary approach for type 2 diabetes management. And low-carb diets are now being recognized as a therapeutic treatment option by national authoritative bodies like Diabetes Australia, Diabetes UK, and the American Diabetes Association. But do they play a role in type 1 diabetes management? When I was doing my dietetics degree, I realized that although type 2 diabetes is saturated with evidence from controlled clinical trials and systematic reviews, type 1 diabetes is not. The clinical practice guidelines for type 1 diabetes fail to provide any specific advice on carbohydrate quantity due to a claim of insufficient evidence. As such, people with type 1 diabetes are recommended to follow the Australian dietary guidelines, which promote a high carbohydrate diet containing 45 to 65% energy from carbs. The problem with this is that the dietary guidelines are not designed to be used by people with medical conditions. This is stated clearly on page 2 of the guidelines themselves. And there is absolutely no doubt that type 1 diabetes is a medical condition requiring specialized dietary advice. It is an incurable chronic disease in which carbohydrate metabolism is significantly impaired. In 2020, myself and a team of researchers from the CSIRO performed a secondary analysis on the Australian Health Survey. And we found that adults with type 1 diabetes had similar energy and macronutrient intake profiles to people without diabetes, and these were consistent with the high-carb diet recommended in the Australian Dietary Guidelines. So despite this apparent adherence to the Australian Dietary Guidelines, people with type 1 diabetes are struggling to achieve glycemic control targets. The average HbA1c of people with type 1 diabetes living in Australia is 8.4%. And worldwide, data from over 19 countries shows that 84% of people living with type 1 have an HbA1c over 7. As with type 2 diabetes, the primary management target for type 1 diabetes is to achieve and maintain an HbA1c of 7% or less, and this is where risk of micro and macrovascular complications are at their lowest. So if low-carb diets work so well for improving glycemic control and metabolic health in type 2 diabetes, can they do the same for type 1 diabetes? In 2018, myself, Dr. Ron Raab, and Professor Kieran Rooney published the first systematic review investigating low-carb diets for type 1 diabetes management. We found 9 studies in total, 4 of which assessed true low-carb diets that were less than 130 grams of carbs per day. Although the collective data at this time was indeed limited, the included studies showed clinically and statistically significant reductions in HbA1c and a reduced use of total daily insulin. There were no adverse events reported from any of the studies. So this systematic review certainly highlighted that there is promising evidence for the use of low carb in type 1, and it's certainly an area worthy of pursuing. So as a means of strengthening the evidence base, myself and a team of incredible healthcare practitioners and researchers from across Australia, some of whom you may recognise, Professor Grant Brinkworth from the CSIRO, Dr. Helen Parker from the University of Sydney, Dr. David Lim, a GP from Sydney, Dr. Kevin Lee, an endocrinologist from Queensland, Amy Rush, a diabetes educator based in Western Australia, Rebecca Johnson, the former CEO of the Type 1 Diabetes Family Centre based in Western Australia, and my PhD supervisor, Professor Kieran Rooney from the University of Sydney. So together we set out to investigate a professionally supported low-carb diet in adults with type 1 diabetes. Our primary outcome of interest was HbA1c, and secondary outcomes included glycemic variability, frequency of hypoglycemia, total daily insulin use, and quality of life. Given there are an extraordinary number of factors that influence type 1 diabetes management, we decided to use a single-arm within-patient controlled intervention study where participants would act as their own controls. And one of the unique things about this study is that it was largely crowd-funded. Thanks to over 30 generous donors, we successfully raised $7,000, and this made a significant contribution towards study costs. So thanks to everyone who donated. But the timing of our study wasn't great. We commenced this trial in July 2021, just as Sydney had gone into a complete lockdown due to COVID-19. Our original plan was to run this study from the new research clinic at the University of Sydney, but we didn't know how long the lockdowns would last. So we made the decision to utilise a fully remote care delivery model where participation was entirely online. This has been done before for low-carb studies in type 2 diabetes, but never for low-carb studies in type 1 diabetes. Despite the challenges of COVID-19 and national lockdowns, we successfully recruited our target sample size, which was 20 eligible participants living with type 1 from across Australia. So this is what participation in the study looked like. It started with a 4-week control period where participants were instructed to maintain their usual diet, exercise, and type 1 diabetes management. In order to be eligible for the study, they couldn't already be on a low-carb diet. They had to be consuming at least 150 grams of carbs a day, and this is the diet they continued to follow during the control period. So this was the higher carb comparator. Participants moved straight into the 12-week low-carb diet intervention period. The carbohydrate target started at 50 grams of carbs per day, and there was opportunity to increase or decrease this within a broader range of 25 to 75 grams of carbs per day. This was a participant-led decision, and it was based on dietary preference and their blood sugar levels. The prescription for proteins and fats was ad libitum, so they were given a list of recommended foods and they were told to eat those to satiety. Minimally processed foods were recommended over ultra-processed foods. They received educational booklets and fortnightly reviews with myself. We also offered them 1 to 2 sessions with our study diabetes educator, and medical oversight was provided. So here's one of the sample meal plans from the study. The meal plans were constructed to help participants meet their requirements for protein, micronutrients, energy, and of course to help them adhere to the carbohydrate target. Each meal included about 150 grams of protein food as a minimum, and that's because we know these foods provide a lot of micronutrients, as I said before. And we also recommended participants add extra sources of healthy fat like butter, cream, avocado, and that was to help them meet their energy requirements on a low-carb diet. This was not a weight loss study, so we were not trying to achieve any kind of calorie restriction. Now, it's worth noting that many of the participants were quite hesitant about this low-carb diet. These are people who had been told for most of their lives how important it is to include enough carbohydrates with every single meal and every single snack. But after looking at this meal plan and learning more about the types of foods they could include on a low-carb diet, they felt a lot more confident with the approach and were keen to get started. 16 participants completed the study in its entirety, including the 4-week control period and the 12-week intervention period. So we did have 4 dropouts along the way. 1 participant was struggling with their pre-existing mental health issues. 1 participant reported a lack of time to commit to the study. 1 participant reported difficulty making insulin adjustments on a low-carb diet, and 1 participant was simply lost to follow-up. Nevertheless, we were very happy with 16 completers, especially given the difficulties imposed by COVID-19 and national lockdowns. All that was going on at the time of this study. So of the completers, the average age was 43 years and 50% were female. The average BMI put them in the obese category, 31.8, and the average duration of diabetes was 21 years. So these were not newly diagnosed type 1 diabetes people. They were people that had had it for a very long time. So here are the individual changes in carbohydrate intake before and after the low-carb diet. The starting intake of carbohydrates was 214 grams per day on average. By the end of the low-carb diet intervention, participants had reduced their carbohydrate intake to an average of 63 grams per day. So you can see that all participants reduced their intake of carbs to some degree, with most participants falling in that target prescription range of 25 to 75 grams per day by the end of the intervention period. Here are the individual changes in HbA1c before and after the low-carb diet. So mean HbA1c levels started at 7.7%. After the low-carb diet, mean HbA1c reduced to 7.1%. The 0.6 percentage point reduction may look like a small change, but it is both statistically and clinically significant. HbA1c reductions as low as 0.3% have been shown to significantly reduce risk of heart disease, kidney disease, stroke, blindness, and limb amputations. Further, as I said before, the target for diabetes management is to achieve and maintain an HbA1c of 7% or less. So by the end of the low-carb diet intervention, participants had moved substantially closer to this, and it was only 12 weeks, and 44% of the group had achieved the target by the end of the intervention. And what makes the improvements in HbA1c even more impressive is that participants can currently reduce their dose of total daily insulin. So insulin use reduced from an average of 65 units per day, and this reduced, from 65 to 49 units per day at the end of the low-carb diet intervention. So data from the Diabetes Control and Complication Study showed that there is an increased risk of severe hypoglycemia and excessive weight gain with high doses of insulin. And with consideration of the high rates of the metabolic syndrome in people with type 1 diabetes, especially in Australia, interventions that achieve glycemic control targets with less use of insulin are extremely beneficial in type 1 diabetes management. Here is the table of all our main clinical outcomes. Aside from improvements in HbA1c and total daily insulin, this study also demonstrated statistically and clinically significant improvements in fasting blood sugar levels, glycemic variability, BMI, and quality of life. There were no significant changes in the negative direction, and no adverse events were reported during the low-carb diet intervention period. I do have a poster in the second room, so if you want to look at these results further, you can go and check that out. So our results support the use, feasibility, and safety of professionally supported low-carb diets in type 1 diabetes management. This study was conducted in a real-world remote care setting that improves translatability into clinical practice. Of course, larger, longer-term controlled clinical trials are needed to confirm our findings. But as you saw, there is a big lack of data in the low-carb for type 1 space, so every clinical trial makes a difference. Thank you.